with complaints of multiple joint pain for last 1 year. The pain initially involved small joints of hand and feet and ankle and knees. The pain was initially severe at the night and in the early morning, which reduced with daily work. Sometimes she took painkillers, but for last 1 month, the pain became more severe and associated with morning stiffness that can't even reduce with taking painkillers or taking rest. She complains of generalized weakness for last 1 month. She can't stand up from sitting position, can't comb her hair by raising both arms above the head. She also complains of facial rash for last 3 months, which aggravated on exposure to the sunlight. She had fever for last 7 days, which was continuous, low grade in nature and not associated with chills and rigor. Highest recorded temperature was 101 degree Fahrenheit. She also had 1 month of oral ulcer. On query, she gave history of 2 spontaneous abortions at 8 and 12 weeks of pregnancy. There was no positive history of this disease in her family. For last 1 year, she was getting treatment from different physicians without having much improvement. After taking proper history, on examination, we found patient was ill-looking, moderately anemic, non-ecteric. There was a butterfly rash over her cheek, sparing the nasolabial fold. She also had oral ulcer in the inner side of the lip. On musculoskeletal system examination, we found the wrist joint, metacarpophalangeal joint and interphalangeal joint were tender, but there was no deformity or swelling was present. On respiratory system examination, there was crepitation on the right lower lung zone and vocal resonance was increased, breath sound was bronchial. So our provisional diagnosis was systemic lupus erythematosus with pneumonia, and differential diagnosis were systemic lupus erythematosus, rheumatoid arthritis, polymyositis, and mixed connective tissue disease. To confirm our diagnosis, we did some investigations. Among them, ESR was raised, rheumatoid doing some relevant investigation. Our confirmatory diagnosis was systemic lupus erythematosus with rheumatoid arthritis, with polymyositis, with pneumonia. After confirm our diagnosis, we initially started giving treatment of pneumonia and vaccinated her against hepatitis B, influenza, and pneumococcus before starting the disease-modifying antirheumatic drug. After vaccination, we started immunomodulator, but at 10th day of her getting this treatment, she had fever again. This time, and put her on from the fever, and we started our immunomodulators again. Day by day, her condition was improving, and day by day, her condition was improving. And staying in this hospital 1 month, she was discharged. This rheumatic case was a management challenge for us. This is all about overlap syndrome, and thank you everyone. This presentation will be continued by Dr. Sajid Sanin Rifa.
Last case, which is about an autoimmune disease called SLE. So what is systemic lupus erythematosus? It is an autoimmune chronic multisystem disease which is characterized by the production of multiple autoantibodies, immunocomplexes, and immune-mediated organ damage. So what does lupus means actually? Lupus means wolf. So SLE is named because of the erosive nature of this disease, which looks like a wolf's bite. So SLE is basically a female predominant disease between the age ratio of 20 to 30 years of old. The female male ratio is about 9:1. Male case is about 10%. Despite significant advanced treatment over the last decades, SLE still carries a significant risk of mortality and long-term morbidity. According to the publication of American College of Rheumatology, a European study of 1,000 patients reveals that a 10 years of survival probability of 92% overall, which is reduced to 88% those who have lupus nephritis. And in one cohort study, renal lupus accounted for the biggest number of deaths where the disease process is less than 5 years of duration. So this is a picture showing the lupus nephritis involving multiple systems in our body, which basically looks like a hose bite from here to there. So now I am my today's discussion is about male SLE, which carry very low percentage but cannot deny it. So Mr. Mujahid, a 20 years old boy hailing from Narayanganj, admitted to our hospital on 27 June with a complaint of multiple joint pain for 3 months, which is associated with the fever, and the nature of fever is remittent. And the joint pain initially start at the left knee and left elbow and also shoulder, and progressively to the small joint of hands and feet. The pain is insidious in onset, and also complained about morning stiffness, and which is relieved by some exercise and also NSAID, but not fully disappeared and again flare up that pain. And on examination, there was no joint deformity or any kind of nodules, any muscle weakness and rashes. And on further query, patient gave some history of high color urine and reduced in volume, which associated with the burning sensation, and there was no history of diarrhea and exposure. On general examination, the patient is ill looking, mild anemic, and all the vitals are normal and within normal range. And musculoskeletal system examination reveals on inspection no swelling, edema and scars, and on palpation there was tenderness present in the wrist and knee joint, and no restriction of the joint movement, both active and passive, and joint temperature not raised. And other systemic examination reveals no abnormality, like respiratory system examination reveals no abnormal breath sound, and neurological system examination reveals that all the superficial and deep reflex are intact and the gait is normal. So our provisional diagnosis that it might be a case of spondyloarthritis, and we also put 3 differential diagnoses that it might be a case of reactive arthritis, a rheumatic fever, or systemic lupus erythematosus, which is very rare. So we admit the patient in our hospital and give treatment. We add a NSAID, which is naproxen, and anti-ulcerant coverage also, and antipyretic. And patient complained about nausea, so we gave tablet domperidone and suppository paracetamol as per needed. And we advise some investigation, which are CBC with ESR, urine routine microscopic examination, serum creatinine, X-ray of the affected joint. And the investigation finding, you can see that all the values are within normal limit to difficult to make a confirmatory diagnosis of the patient. So after 5 to 6 days, as the pain was subsided and patient was febrile for 2 days, we discharged the patient. The story could be end here, but on 3rd August of 2024, patient again admitted to a hospital with the same complaint, but this time the joint pain was so much severe than the previous one, and also high grade fever, and also had some rash in her face. So beside the routine investigation, we also give some special investigation, but the routine investigation reveals that on CBC, hemoglobin was 8.3 gram per deciliter, CRP also raised, ESR also raised, and serum urea 62.9, serum creatinine 2.18. So something was going on the investigation profile. So we further for the evaluation purpose, we also advise some special investigation. We gave 24 hours urinary total protein, anti-double strand DNA, serum C3 level, and total protein was 3.15 gram, C3 level reduced, which was 0.5, and we also exclude the tuberculosis. We gave Montauk's tuberculin test. If you closely look at the second investigation, this one single investigation totally changed the story. Anti-double strand DNA was more than 800 unit per ml, which should be less than 30. So there must have an autoimmune disease, is refer. So we further do ANA profile, and ANA profile reveals that they are nucleosome positive, histone positive, NT Smith DNA was positive, NTQ antibody positive, and double strand DNA also positive. So our confirmatory diagnosis was at the time systemic lupus erythematosus with lupus nephritis with Liebman sac endocarditis, because transesophageal echocardiography reveals that there was infective endocarditis and mitral regurgitation. So as soon as we diagnose the patient, we start the definitive treatment. There was broad spectrum antibiotic, tablet prednisolone was given, and before start the DMRD, which was disease modified anti-rheumatoid drug, we vaccinate the patient first. We vaccinate the patient against hepatitis B virus, influenza virus, and pneumococcus virus. And we start tablet Reconil, which was hydroxychloroquine sulfate, tablet alendronate, which was bisphosphonate, and phenocept, which was mycophenolate mofetil. We adjust the dose according to the patient age, weight, and condition. So this is a picture of Mujahid, which was taken after 6 months from the first day of admission in our hospital. Now patient fully recovered from the disease process, but the treatment is still ongoing now. So there is no such complaint during the last follow-up in our medicine outdoor department. And I personally meet the patient 20 days back. He was so well and delighted that I was hesitant to address him a patient anymore. So this is all about patient Mujahid, the SLE boy. Last but not the least, patient mother also complained about the same problem, that joint pain and also fever. So we, beside the routine investigation, we also advise her ANA profile, and here we found that there was also anti-double strand DNA positive. So thank you all.
Learned audience and dear students, good morning. Actually, these instead of one case, we decided to present 3 cases here. Time is very short, and this session has been split in 4th section actually. So why did we have done this? Because when we see a scientific presentation, in many cases many nuances are missed actually, because we see that DNA is positive, RA is positive, HLA-B27 is positive, and okay, it's a straightforward case. What's so important to discuss about it? So I like to share the stories behind these cases, because if you noticed, few patients, all the patients were almost suffering from, one of them was suffering from 4 years, one years, one more than 1 year. So it was not that much simple and easy. Let's give us a chance that whether we can do anything. Okay, they obliged, they come, they admitted to Ad-Din hospital. The first day, what I did, the interns done a very good job of clinically evaluating the patient. And on the first day, I took 2 consultations, one from the pediatric department and one from the orthopedic departments. And both come out with some, because I have to exclude other diseases to reach my diagnosis. I have a hunch that what is this, but I have to exclude others, because as he has gone through so many investigations and procedures. So, and both from pediatrics and orthopedics, it has come out that no, it's not muscular dystrophy, or it's not myopathy, or we don't think it's a neurological condition. Okay, then I send the patient for NCS and EMG, and that also come out normal. But here, the story doesn't end here, because if we only depends on the reports, I could have closed the case earlier, because the reports were normal. So frankly, I called my neurologist friend that actually he has done the NCS and EMG. I called him and I told him that see, you have done this NCS and EMG, you said it's normal. Now I am sending the patient back. Now you see the patient clinically and tell us what is your opinion. And there was Nurul Huda at that time. Nurul Huda went with the patient to doctor's chamber, and the neurologist, Dr. Renayat, I should mention his name also. And he after examining and seeing all the things, and he is telling that no, we are positive, there is no neurological involvement. Nurul Huda was there, and he said, sir, please write down this to your prescription because we are in trouble with this patient. So at the end, after exclusion of all other conditions and depending on our clinical settings, we started to give him optimum doses of NSAIDs and physical measures. Measures like exercise and other things, and started first on one immunosuppressive immunomodulator, methotrexate. Later on we have gone for methotrexate and sulfasalazine. The journey begins. The recovery was good, they were very happy, but it was kind of incomplete. It was not going to, we are not achieving the up to the mark response from the patient. So I have counseled the patient long back that if required, can you afford a more expensive drug. So after 1.5 years, the father told me that let's go for that drug. So we have started adalimumab. Now that creepy young child has become a naughty boy actually. He come to the hospital, he move all around the hospital, and he has some things for himself to do in these hospitals and go back to his home and come every fortnightly. And what will happen next we actually don't know, but so far what we have done is okay, it's okay. Now about the second case, Labuni Akhtar. When she admitted, she was also bedbound. She could not move. We sent the investigations and came out with both sides. It was kind of overlap syndrome at both the clinical and investigations report of both the diseases were kind of positive. So rheumatoid arthritis and systemic lupus erythematosus was the diagnosis. But there is a catch there because patient has pneumonia. So we have to treat pneumonia. We have treated her for pneumonia and with some painkillers. So pneumonia improved. We prepared the patient for after vaccination and other thing for the immunomodulators. We have started the immunomodulators and patient was improving, and when we are almost thinking whether we can discharge the patient, another thing come, patient develop fever again. So it was exhaustive because for pneumonia treatment it was 10 days gone, then preparation for the immunosuppressive, we had to give the vaccination and other things, another week gone, and now fever again when we see the patient is. So already patient has pneumonia, patient has rheumatoid arthritis, patient has systemic lupus erythematosus, and now fever again. So out of curiosity, as dengue was endemic there, we have sent for the dengue test and it came out positive. So we have to stop all the treatments again and wait for the treat conservatively and wait for the recovery of the patient. Okay, patient was recovered and we start the treatment again. The story didn't end here, and the patient is very much happy. There is no pain, there is because SLE and RA is not affecting any vital organs. So the patient is very happy. But one thing strikes me one day, I was in the round and she was smiling and I asked him about her activities of daily living. That can you go to the washroom, can you take care of yourself, how about your take care of hair? And she said, no, I cannot move, I cannot go to the washroom without help. I said, why? You said there is no pain and other things. She said, I feel extremely weak. Why? I don't know, but I feel weak. I asked her, show me your weakness. So with great difficulty she came out of the bed and she sit and she couldn't rise. We helped her and asked her to sit again, and we helped her and she couldn't move her lower leg. So contrary to the previous case, it's totally different. that was only pain, but here there is pain and there is weakness, and we all, with all our efforts, actually we couldn't find this weakness earlier, because there are so extreme pain that evaluation of muscle strength was virtually impossible. So we have gone for CPK, which was very high. We have gone for NCS and EMG, and inflammatory myopathies came out. So rheumatoid arthritis, systemic lupus erythematosus, pneumonia, later on dengue, and now myositis. We tried to treat her. She recovered. Went home. Later on came back to us with some complication. We asked to get her admitted, but somehow she couldn't. But later, after that, she came to our emergency one day with convulsions, with an oxygen saturation of 60%. Our colleagues were present there, Dr. Joyanto, and he called me. We treated the convulsion as a case of status epilepticus, or convulsion seizure emergency, and after stabilization sent the patient to Mokbajar Addin to ICU admission, and after few days actually the patient died. Right. So not all the stories ends with happy results. It's not like that. We have done our part. Abir is doing well, and she is no longer with us. But the conditions were also very serious. Now the third case, the Mujahid. Mujahid was, when I first saw Mujahid, my instant diagnosis was it's a case of spondyloarthritis, because a young man, 20 years of age, with multiple joint pain, what else it could be? It's spondyloarthritis. But he got admitted and went through the investigations and found out, and with clinical context, it was found out that he is having SLE, though rare, but he is having SLE. And there is something interesting happened in this case. One of the attendants asked me, can you treat this case? So it's a case of SLE, how can I say I treat this? Nobody can say confidently that I can treat or I can cure this. So they are always with me. I ask them to please refer this patient later on. Let's see what happened. And the patient came back to our hospital after 3 months. By that time, many things happened. He has been admitted to many hospitals in Dhaka, and he was admitted in 3rd August. And I instantly, over telephone, my instant reaction was, refer the patient again. This is no time. You can remember the time, 3rd August. Refer the patient again. But they have given the response, and we got the opportunity to treat the patient. The problem was, in this case, was SLE was there. There is fever, and there is endocarditis. Repeated blood culture has been done. Repeated blood culture with no growth. After admission, we have also done this, no growth. But antibiotic was on, and it was going on. After few days, patient developed edema. I went for a urine test, which showed there is protein in the urine, along with there are some cast. So renal involvement is starting, which was not there before. And then I call our cardiologist. Hey, is there anything can be done that whether that endocarditis is infective, because SLE also might cause endocarditis, and there is a name for that Liebman-Shack endocarditis, sterile endocarditis. So he done the echo again and called me. There is vegetation, there is regurgitation, but we can't say whether this is bacteria or not. Now here, this is the situation: patient having active SLE, patient having endocarditis, patient having high grade fever, and new onset lupus nephritis. I am giving rounds day after day, and actually nothing is changing. And I am telling the story here in front of Joyanto. One day in the round, I asked Joyanto, what to do, Dr. Joyanto. if it's bacterial cause or infective cause of endocarditis, it's not responding anyway, whatever we are doing, it's not. There is lupus nephritis. If we don't treat that condition, the patient, we will lose the patient anyway. So if it's endocarditis bacterial, we are losing. If it's SLE with active nephritis, we are losing. So what to do? What to do? Patient's mother was there, and she was eventually later on found out as a case of SLE, though milder form. We discussed this scenario with her, that whatever the path we take, this might cause harm to the patient, But if we do nothing, it's certain that the patient is deteriorating. There is no doubt about that. So what have we done? That we have put the patient on highest dose of antibiotic, actually, covering all the imaginary bacteria and organism, we have covering everything. And we have put him on immunosuppressive also, high dose of steroid and mycophenolate mofetil and other things. And here is the catch. This is this case could go either way very easily, very easily. We could lose the patient within next 3 to 4 days or 1 week. But there was a logic that why we are doing this, and we explained this to their guardians and taken their consent, that if we do nothing, we are losing, so whether we can do something. And actually, frankly, within 2 days, the opposite happened. The patient improved dramatically, and here is the patient now. So, and still he is on very high doses of steroid is tapering, we are now, but immunosuppressive, mycophenolate mofetil is a very strong immunosuppressive. He is on very strong immunosuppressive, and they are doing well. So not everyone is doing well. So with that view, I like to thank everyone, and we will begin the question and answer session now.
ল্যাবরেটরিতে বেশ কিছু রিউমাটোলজিক্যাল ডিজিজকে নিয়ে আসার জন্য, কিন্তু আমাদের জন্য খুব কষ্ট হয়েছে যে ট্রেসিং করা আসলে কোনটার সাথে কোনটা। তো আমার কাছে যেটা মনে হচ্ছে যে জুভেনাইল ইডিওপ্যাথিক আর্থ্রাইটিসে আমরা আশা করছিলাম যে যেহেতু আর্থ্রাইটিস এখানে স্টেরয়েড দেওয়া হবে, ট্রিটমেন্টের রিপিট করলে ভালোই করে দেখা যায় যে একটু স্টেরয়েড ইউজ করা হয় না। এটা আমার একটা প্রশ্ন কেন। আর সেকেন্ড প্রশ্ন ছিল এটা যে যেহেতু হাইড্রোক্সিক্লোরোকুইন আমরা দিচ্ছি, স্পেশালি লুপাস নেফ্রাইটিসের এই কেসটা থার্ড কেস, তো সেখানে তো হাইড্রোক্সিক্লোরোকুইন দেওয়ার আগে প্রোটোকল হলো যে তাকে অপথলমোলজিক্যাল অ্যাকুয়েশন করা, ভিজুয়াল অ্যাকুইটি দেখা, ফিল্ড অফ ভিশন দেখা, এটা করা হয়েছে কিনা, এটা আমার প্রশ্ন। সেকেন্ড থার্ড কোশ্চেন ইজ রোগী যেহেতু তার ডার্মাটোলজিক্যাল কিছু ম্যানিফেস্টেশন আছে, তার বিশেষ করে ফটোসেন্সিটিভিটি, ওরাল আলসার, ডিসকোয়েড র্যাশ, তো এটার জন্য সে সানব্লক ইউজ করছে কিনা অ্যাজ এ ট্রিটমেন্ট পারপাস। থ্যাংক ইউ।
Okay, thank you for the questions. And regarding first case, why don't we use steroid? Actually, steroid is a second line management here. First of all, as for pain management, NSAID optimization is important, and pain was kind of relieved with the NSAID. And disease for disease management, we have gone for the immunomodulators drug. And if I am not mistaken, actually at the first few days perhaps we have given some steroid also. And regarding the steroid use, there is no role of steroid in spondyloarthritis, and we should be very careful to prescribe steroid. I am coming to this point a bit later. About second case, okay, yes, ophthalmological opinion was taken, and sunscreen was advised actually, frankly. And regarding steroid use and other things, if those cases were kind of difficult, last night we have got another admission. Patient name is Joydev. He has came from Hatia, and he is suffering from 2003. he has gone to Square, he has gone to Green Life, and he has gone to Chennai also for his management. And from 2003 to 2025, he is suffering. His name is Joydev, just admitted in our hospital. So these cases are a bit puzzling. It's not that straightforward. That's why we have approached this way. You have said rightly that it's a bit puzzling, tracking all the cases, which one we are talking about and other things. But this is not straightforward cases to this.
Presence of student is very minimum compared to other days. It's not a good sign for the CME. I think in the next time the presence of student will be ensured. And another thing Ratul was asked, I want to add to those questions, why we should do vaccination. Actually, in here two group of people are working for the patient of rheumatological patient. One is orthopedic surgeon and another group is medicine associated with rheumatologist. Medicine and rheumatologist do the vaccination and with the orthopedic surgeon not do the vaccination. And here is the actual debate why we should go for vaccination. And at least last 1 year I am asking myself why we should not do the vaccination. Actually we are doing many vaccination for many diseases from the childhood, from after birth. And as I am taking immunosuppressive drug, so I am getting immunosuppressive day by day after taking rheumatological drug. So if I take this vaccine, this will not an issue. This will be helpful. At least this will not do harm to me. And another thing is, many patients have diabetes. They have already immunosuppressive. So this should be controlled. And another thing is, sometimes we just start the anti-rheumatic drug. And one of my friend from medicine of Chittagong Medical College, he was asking, you orthopedic surgeon are killing the patient, even though you are not searching for the occult tuberculosis. Okay, I also say something, that is not the issue, but I think we may start this because this will not do any harm to the patient, rather may help or give some benefit to the patient. And another thing, after CME, I was talking to Tarek sir that during a morning session or CME, the way of communication should be in English. And we should give some attention about this thing, because we people of Bangladesh are actually can't speak English. If you attend in any kind of international conference, with the Bangladeshi people actually remain silent because we can't speak in English. And if you speak in English in an international conference, they can, in a first word, they can understand that these people from Bangladesh. So what is the condition of our speaking in English? So we should try to develop this thing. Okay. And another thing, it's a rheumatic disease or rheumatology, it's a teamwork. This should be treated by orthopedic surgeon, rheumatologist, physical medicine specialist, physiotherapist. So it's a combined work to give a fruitful outcome of a patient with rheumatological disease. With this I conclude. Thank you. Thanks to you all.
Now I would like to tell our chief guest, Professor Dr. Rheumatic sir, to have some words regarding our session.
Many thanks to the medicine department for their nice presentation, and I want to everyone to participate regularly in this CME program. If we present in this CME program and participate,